The purpose of this evening's talk is to try and give you an overview of bipolar disorder, what it is, and how you can get your head around it as a concept, because for many people it is a little puzzling. For many people who come to a talk like this or watch it on YouTube, I have got to make sure that I'm not too repetitive. Got to change a little bit of the presentation. And always at this talk, we try and introduce some new, not necessarily basic concepts about bipolar disorder, but an understanding of maybe what's happening in recent research. And I'm going to start with that in the beginning, because I think that as the night goes on, I'll forget about it. One of the interesting things about bipolar disorder is that something like 46% of people who have recurring depression at an early stage in life go on to develop bipolar disorder if observed over a 15-year period. Pretty short period of time, quite a big conversion from recurring depression to bipolar disorder. Wouldn't it be useful if we could work out which people go that way and which don't? Because it would have a lot of predictive worth getting to understand that particular group and to study them. So one particular interesting piece of information that's come from research recently has been that those who have recurring depression and go on to develop bipolar disorder have, at the time that they have just the recurring depression, a high level of uric acid. Uric acid is the component that's implicated in causing gout, the painful hot big toe syndrome. Okay? So something as simple as that seems to be a very good predictor, based on the research to date, of those who have recurring depression and may develop gout later, or develop bipolar disorder, gout of the mind in a way, which is maybe an interesting concept. Does uric acid really cause bipolar disorder? Anyway, it opens up a lot of other possibilities, and something that I'm sure that if it is validated by some other studies, I mean, we've known for quite a long period of time that the occurrence of gout in people with bipolar disorder is quite high, and was thought, well, that's probably related to weight gain, the effects of medication generally, and so on and so forth. But we're talking about people who are tracked way before they develop bipolar disorder. Next interesting piece is in connection with why it is that if we think bipolar disorder is a highly inherited condition, why is it that it doesn't show through in certain families where you'd expect it to be, where there is already in a previous generation maybe a high occurrence of bipolar disorder? Or why is it that when you've got identical twins where one of them has bipolar disorder, that at most in the fellow twin the occurrence of bipolar disorder is about 70%? And why is it that it's so complex trying to understand the genetics of bipolar disorder? It's probably the most complex condition to understand, that in one way there's evidence that bipolar disorder is largely determined by genes, but when you actually get down to the minutiae of it, it's almost as if it evaporates. So one of the possible explanations for this is that gene activity and the things that control gene activity looks to be more complex. And it's complex in the sense that the structure of the DNA molecule can be interfered with by other genes, number one, other chemicals, number two, and stress in a person's environment. So stress and a person's life experiences at an earlier age in life may also switch on or switch off genes in a way that, and thus determine whether a person who has technically should be developing bipolar disorder, we say, within an identical twin setup. In other words, if bipolar disorder is very significantly genetically determined, you would expect if one identical twin has it, there's a very, very high chance of the fellow twin having that condition. And this again opens up another pathway to possible therapeutic interventions in the future that we may learn ways of switching off the genetic impact coming from the original gene that is causing bipolar disorder. And the final piece that I want to introduce to you is this concept of how best to treat rapid cycling mood disorder. Many of you will know that treating rapid cycling mood disorder is quite problematic, because if you read studies on it, it indicates that any one particular type of treatment only works for about 30% of people who are having many, many cycles of mood of a bipolar nature in the course of a year. One interesting study that was published in the past few months was on looking at the role of thyroid hormones in stabilizing moods. We've known for a long time, or at least it's been in the literature for a long time, that a particular hormone called T3 was effective in stabilizing bipolar disorder. So the thinking here is this, that if you look at people who have bipolar disorder and they have an equal amount of depression and elation, and they have big highs and big lows, but fairly substantial periods of normal mood. When you look at their thyroid hormone, it's quite normal, it's bang in the middle. If you look at people who have a lot of highs, often their thyroid function is right up at the upper limit of normal. And then people who have rapid cycling mood disorders tend to have hormone profiles that are at the lower end of the normal range, or slightly below that again. Okay? So why was that happening? Is that secondary to the mood itself? In other words, if a person is having a lot of depression, does that in turn mean that their whole thyroid system and endocrine system is a bit dampened down? Well, while we don't understand exactly what's happening there, what is emerging is that thyroid hormone can be useful for it. So this study looked at, if you have people with rapid cycling mood disorder and divide them up into three groups. One, a group that are given, they're all given their usual treatment. And the add-on treatment for these three groups is T4 for one group, T3 for the second group, and the other a placebo. And it shows that people who are given T4, which is the main thyroid hormone that the thyroid gland excretes, they have fewer days in depression and fewer episodes of depression when on T4. And that's over a relatively short period of time. So again, an interesting study, and it's also interesting from the point of view that heretofore we thought that T3 was probably more effective. But again, as with all these researches that come out, they've got to be replicated a few times before you can actually fully endorse using something like that. So again, it's just to show you that there's always some work going on that has a therapeutic point of view and trying to establish better outcomes for people with these conditions. So in terms of understanding bipolar disorder, what is it? It's an increased rate of thinking or activity within our mind and body. We have a thinking wheel within our brain. It goes at a certain rate. When a person is depressed in the bipolar sense, it's slowed down. When a person is high, it's speeded up. Now, this is crucial to the understanding of bipolar disorder and to the prevention of misunderstandings of what bipolar disorder is not. You see, what you will find is that we can't always rely on how a person is feeling to diagnose bipolar disorder, or even that we say the depression of bipolar disorder. You might think if somebody says, well, I'm depressed, and they have a history of bipolar disorder, well, that must mean they're currently depressed. But it's not as simple as that, as you'll see when we look at the first slide. So, as I say, it's an alteration in the rate of psychomotor activity. That's the mental and physical activity in the brain, is the best way of understanding bipolar. That's the core, and everything else then is sort of put on as extra layers on that. The person's personality, the stresses they're under, and so forth. So what happens in depression is that this thinking wheel is slowed down. And a few things happen then from that. One is, the most important thing is, the person has difficulty projecting things onto the visual display unit in their mind. We all have a visual display unit in our mind. We take it for granted. When you mention it to people and say, well, what are you on about? Well, what are you doing tomorrow? What are you doing next weekend? Images, when you ask that question, show up in your mind, and you talk to them, of them. That's how we have our mind focus. But the point is that when this wheel is rotating very slowly, it can't get the thought up onto this visual display unit. Now, two things happen with that is, one, when you ask the person how is the future, they'd say there is no future, or it's bleak, or it's blank, just the words they use. And consequent to that is the person has diminished energy, because energy is a figment of our imagination. If we can get a picture up there that we want to chase, we'll have energy. If we don't have a picture there, we don't have energy. The next thing that happens is that with the slowed thinking wheel, the person's thinking is very much focused on the past and on the negative aspects of the past, the pains, the upsets of early life, misdeeds that the person may think they've engaged in, but very often quite trivial ones. But in the depressed state, the person thinks of them in a very negative way. And the next point is that with the slowed thinking wheel, the person has difficulty concentrating, because to absorb information, our brain has to be going at a certain rate. If it's slowed down, we just can't suck up that information, whether it's a string of phone numbers we're given, or a person's address, or anything we read. And the other point then is that the person's mental and physical awareness is shrunk. It's introspective. So the person becomes more self-conscious at a sort of a social level, where they may feel conspicuous, awkward, uncomfortable in social situations, but also in that introverted state, they're very aware of their body. See, normally we are outside, we're thinking ahead all the time. We're thinking up here, but our thinking goes this way and introspective during a depressed state. The opposite happens then during elation. With this thinking wheel now being speeded up, the person's thinking is into the future, and there are plenty of things on the visual display unit. The person's mind hopping from one to the other, and it's much less about the past. And initially, the person with this speeded up wheel, they can concentrate much better, and as the wheel gets faster and faster, their concentration then becomes impaired, because their mind is going so quickly that as you're even talking to the person, you can see their eyes flicking back and forth, which is a reflection of the amount of thinking. Whereas when somebody is depressed, they're vacant, they're staring into space, and you feel almost disconnected from them in that state. The other point then, just to show the symmetry of this, is that the thinking is extrovert rather than being introvert. The person now is much less self-conscious. In fact, one of the things a person will say when they're mildly elated, I wish I was always as confident as this. In other words, things just bounce off them. And often then at a physical level, the person is unaware of aches and pains. If they have maybe asthma or a cardiac condition or something like that, they will often go through the pain barrier and not be affected by these things, and often then cause damage to their physical being. So again, these are just the main symptoms, which I'm not going to labour on, but being down, low, depressed. And remember that often the first symptom of, at a feeling level in depression, is anxiousness stroke panic, because often in the lower grades of depression, its anxiousness is more to the fore. The most common symptoms, though, in bipolar depression is tiredness, feeling drained, flattened, leaden. The person's sleep is oversleeping or napping by day and early morning wakening. Typically, people with depression of bipolar disorder, they don't have trouble getting to sleep. The person's thinking is slowed down, poor concentration, and the thoughts are negative. So the person has reduced interest in food, work, sex, TV, their usual pursuits, and then a lack of interest in themselves as well, which we look on as self-esteem issues, self-worth, and so much so that the person may feel worthless or, at the very far extreme, feeling evil or wicked or damned. Always with depression, there's an element of tightness in the body, and that muscle tightness can cause almost any symptom you want, from headache, chest pains, back pains, bowel ache, pains in the ears, because every part of the body actually has a muscle stitched in there someplace, even within, we say, the bile duct or ducts from the pancreas gland or whatever. And so sometimes you'll find people when depressed have the weirdest physical symptoms, but they can use that as a spotting technique, because almost every time they get depressed, it'll be the same pain that will come to give them an early warning symptom of where they're stuck at. And finally then, not wanting to live, where the person sees the future as bleak, blank, and they have suicidal thoughts. Then inhalation, never felt better. Great, totally free of anxiety. Their energy is boundless despite maybe less sleep. They typically have trouble getting to sleep or wakening within 2 or 3 hours of getting to sleep, and at the same time not feeling tired the next day, a reduced need for sleep. The person is aware maybe of having rapid thoughts, over-talkativeness, and a restless mind. And in terms of interests, everything excites the person, everything glistens, be it sex, religion, politics, or whatever your addiction is. The value the person puts on themselves is they're often very highly confident at one level, right up to the far extreme of feeling, having grandiose thoughts about their abilities. And as I said, very often in terms of aches and pains, the person is relatively unaware of these things, so that they break through stiffness and breathlessness, but often damage their bodies indirectly in that way. And typically the person has a feeling in ordinary elation that they're going to live forever. Now, in terms of the types of depression or bipolar disorder, bipolar 1 is where the high side, the manic side, is quite extreme, and is frequently, in days gone by, would be defined as bad enough to land the person in hospital. And it's typically followed by a depression, and the person can be well for months to years later. Probably the rate keeps varying, but something like anything from 70 to 90% of people who have a one-off episode like this will have a recurrence. Next then is bipolar 2, or should I say, unipolar mania. Now, many people don't really recognize this as a phenomenon in its own right, but frequently people who have the onset of bipolar disorder at an early age in life, they will have just manic episodes only. They may have a little dip in mood like this that they'll describe as tiredness, but it's not sufficient to be called depression and shouldn't be treated as depression because it's self-righting of its own accord. As you'll see in a moment, there's a particular reason why we need to recognize unipolar mania. And then we have bipolar 2, and here in bipolar 2, the highs are less severe. In fact, the doctor may not be aware of it, nor the patient, and sometimes the families aren't even aware of it until you ask them to tabulate the person's mood over a few weeks or a few months. So the person may come in with a history of recurring depressions. No, I never get high. But until you actually describe the more subtle aspects of high and they begin to document it, it's only then that they realize, yes, that's been happening. And again, to distinguish it from rapid cycling, the person is often well for months in between times. Then bipolar 3 is basically, I'm going to abbreviate it like this, it's bipolar 2, i.e. generally mild highs, but it's triggered by substances, including antidepressants, steroids, alcohol, substances of one sort or another. In other words, if the person wasn't on those substances or wasn't triggered by those, they wouldn't get the bipolar episode at that point in time. We don't know, for example, supposing they got by that point in time, will the bipolar disorder at a later stage just come out of its own accord? The answer is probably yes, but we can't really prove that. Now, rapid cycling bipolar disorder is where a person has 4 or more highs and lows in the course of a year. It's an arbitrary thing because you have to be diagnosed as depression using research tools. You have to have the depression for 2 weeks as a minimum, and the high must be either 4 days for hypomania or a full week for mania. So when you divide that into 56, you begin to work out that there's a limit to the number of rapid cyclings in the year, according to the formal way of looking at these things. But in fact, there are people whose mood will vary every few hours, on and on and on. There'll be other people who are high for maybe a week, down for a week, and back into the high again, and on it goes. So it merges with what we call continuous cycling, where there's no let up in between. The final piece is with mixed mood state, and this is where the person has what we call a dysphoric high. It's several names on this, because where the person has what we call an unpleasant high or a dysphoric hypomania, or that's formally called in the literature a mixed mood state. Okay, so I'm giving it a fuzzy edge just to distinguish it. So the point about this is that whereas in the formal literature that you look at, mixed mood state is only in relationship to depression and elation. But in fact, you'll meet people who have mania that is mimicked by depression, anxiety, agitation, or paranoid states. Okay? So what you've got to come back to then is, what is the core of bipolar disorder? The core of bipolar disorder is alternating episodes of overactivity of the brain and underactivity of the brain relative to what's the normal rate of activity for that person. Okay? So whether they tell you they're experiencing depression, anxiety, agitation, or paranoid state, it's kind of almost irrelevant to the diagnosis. But so the core aspect of the condition is what one has got to focus on. So in other words, just because you've concluded that the person has, we say, an anxiety state, the next question is, within that anxiety cluster of symptoms, is there a drivenness about the person? Is the person very over-talkative? Have they very marked trouble getting to sleep at night? Do they jump from one topic of conversation to another? Have they tremendous energy? Despite all their complaints of anxiety, how much work are they getting through? Are they getting into conflict with people? Is there an element of anger there? So within an anxiety, you've got to see, is there within that a drivenness that is more in keeping with a bipolar phenomenon than anything else? Does that make sense? And it's the same then with depression, agitation, paranoid states. So what this circle, or two circles here, is to represent the similarity in symptoms between the dysphoric hypomania and depression. They overlap with one another almost 100%. Sometimes it's generally very difficult for people who are even experienced sufferers, if I put it that way, of bipolar disorder to distinguish dysphoria or an unpleasant high from depression. But the characteristics that are worth looking at is, one, if the person is complaining of depression, question, do they have trouble getting to sleep at night? Do they feel worse in the evenings? Because depression typically feels worse in the mornings. Is there anger or irritability as part of their condition? Anger or irritability is not part of depression in an ordinary sense. Now, yes, there are plenty of people who are angry and depressed at the same time, but one has got to work out which is the driver here. And weepiness. I'm not going to make too much of weepiness, but it's just to remind you, it's not a key thing, but within the context of depression, most people who are actually significantly depressed with the bipolar illness actually can't cry. They might if the depression is very mild. So the biggest difficulty in diagnosing bipolar disorder, it's very straightforward in many respects when you look at the typical symptoms, but a myriad of different conditions, many conditions, can have a bipolar component. And the reason why it's so important to identify that, take for example, if somebody complains of depression and you accept it at face value that it is depression, but in fact it's an unpleasant high, and you treat that with an antidepressant, you're going to worsen the condition. Likewise with anxiety. If you start treating somebody with anxiety with CBT and they're high at the same time, it's not going to cut any ice. Even a minor tranquilizer, if you give it to somebody who has ordinary anxiousness as general anxiety, it will be helped in the short term with a minor tranquilizer. But on the other hand, if there's an underlying bipolar component causing that symptom of anxiousness, a minor tranquilizer just won't work. So I'm not going to labour on the genes and environment other than just to point out briefly that for bipolar disorder, it's known that something like 70% of the contribution to bipolar disorder is genetics, and the other 30% is environment. Now, by environment, we mean things like substances, alcohol, bangs on the head, brain tumours, MS, sex hormones, big hormonal changes in a person's life. But it's not straightforward in the sense that that's the average, 70-30. But for some people it might be 10% genetic and 90% environment, or 30% genetic and 70 and so on. But the point is when you tot them all up, that's what the average is. And then the problem comes, well, where is the gene? Why can't we find it? We don't have the answer to that, but it doesn't mean that it hasn't a genetic effect. What's becoming evident is that it's multiple genes, each having a small effect, is the problem. Now, you've got that in diabetes as well, but it's been possible to unpick those genes and work out exactly what's going on, but not for bipolar disorder. So, just to remind you again of some of the environmental factors, it's generally stress as stimulants. In other words, when we're confronted by a situation or something goes wrong in life, we get into a wound-up state as a way of dealing with it. And it's that type of phenomenon then landing on somebody's head who is prone to being able to go up into 7th or 8th or 10th or 12th gear, whereas other people cut off at, we say, 5th gear. They can't go beyond that. There's sort of a block within their system that stops them going up and up and up in terms of mental activity. But it's at that point. So, for example, a bereavement may do it, because the person might get wound up and agitated and angry at what's happened and so on. And for some people, that will trigger it. So that's how stress seems to be an issue there. And then the substances are steroids and hormones, because most, we say, sex hormones have a steroidal-like effect. Antidepressants, adrenaline, and certain Parkinsonian drugs. Alcohol and street drugs, initially, yes, anxiety reducing, but for many people, they will elevate mood. So what happens is these substances, all of them, give you an upswing in mood and then a downswing. But very often the upswing is missed, nobody observes it, and the person is just complaining of being depressed. It's not picked up. And then the environmental factors that are just worth looking at. Moving through time zones and changes of seasons. Infections and immune activation, including hay fever. So you will see some people who, every time they go high, it's associated with an infection. Maybe I've known people who've had recurring urinary tract infections, and that for some people, just simply being put on a preventative antibiotic stops the rapid cycling for that person. Now, I won't say they're absolutely typical, but if you look at simple things like when a person gets a virus, frequently that causes mental agitation, and then when the mental agitation is over, the person is lethargic and tired, and we say in something like viral hepatitis or infectious mononucleosis, many viral things, it's very recognized that there is this biphasic aspect. So there's something within the viral phenomenon or the body's immune system reacting to it that seems to trigger it. So this may be frequently when we relax, go on holidays, our immune system sits on the floor. And when we're active and engaged and really going full throttle, we're less prone to infections. And there's some link between that and bipolar disorder. You will often see people, for example, who might be very unwell mentally, hospitalized, they get an infection, and their mental state improves like that overnight. When the infection is sorted, they go back into that state again. So there is a very close relationship. Some people will maintain, don't know if there's enough proof of it yet, that the pollen count at certain times of the year is the reason why there's seasonal variation in mood. In other words, they don't really accept that it's related to the amount of daylight and so on, but that it may be associated with exposure to pollen in the air. Then things like pain, sunburn, and so on, they work by disrupting a person's sleep. If somebody has a history of bipolar disorder and they want to get a mood disturbance, all they've got to do is not go to sleep for a night or two and they're off. So in other words, that sort of sleep disturbance, night work shifts, travel through time zones, they all work on that principle of disrupting the sleep. So when people go abroad to the sun on holidays, you have a lot of factors coming into play, both in terms of going through time zones, sunburn, pain, alcohol. Anyone mention it? No? And then the physical end, brain tumours, multiple sclerosis, concussion can lead to mood disturbance. Now, just again to remind you what bipolar 1 disorder is, and we just now go on to look at the treatment of these different conditions. So, for people where it's mild, sometimes lithium can be a useful tool, but more often what would tend to be used if it's a mild episode is that one of these compounds, the antimanic agents, because they can be used in a low dose while one is waiting and seeing, is this a more severe episode of elation or mania? If it does become more severe, very often lithium is the best treatment because it's more predictable in ending the episode of mania within a defined period of time, whereas frequently one gets the impression that some other compounds, such as what are called the antipsychotic agents, they often take the top off the elation, but frequently underneath it, a lot of the behavioural disturbance associated with the elation, maybe something like overspending, still continues, despite the apparent improvement in the person's mood state. And then for more severe episodes, frequently the antimanic, or also what are called antipsychotic agents, such as olanzapine, quetiapine, amisulpride, and so on, they need to be used before commencing the lithium, just to try and settle the person down a little bit. The management of the depression of bipolar 1 disorder, the important thing is just to treat the depression as gently as you can, because what you're trying to do is get the person out of the depression without kick-starting a high. On the other hand, you can't ignore the depression and wait for them to recover. So something like lamotrigine is gentle and quite an effective antidepressant. The other ones that are useful are carbamazepine and oxcarbazine. They're both Tegretol and Trileptal, which you may know them as, and they do have, in low doses, a good antidepressant effect. And then if you have to go the next step, to a low dose of a standard antidepressant. Now, so medication in terms of preventing the bipolar disorder. The nature of bipolar disorder is that it is a recurring condition. There may be certain circumstances where it's going to be there as a one-off episode, but that would be maybe related to very often an environmental factor that is not, the person isn't going to be exposed to again. Maybe street drugs or a very excessive intake of alcohol, or a head injury or something that one can't really say with certainty that there's going to be a recurrence. So this is why preventative approaches are necessary, and lithium is generally seen as the best preventative agent in terms of having lesser side effects than many other medications, but it does need to be monitored carefully. It's not without its problems, but for most people, if precautions are taken and lithium and related blood tests are carried out, it's a very effective treatment. Again, in terms of preventing relapse, things like carbamazepine or oxcarbazepine or lamotrigine in low doses can be helpful. So what you may find is, for example, somebody who was on lithium, that they're no longer getting the manic episodes, but they're still getting depressions, but the depressions are milder and less prolonged, and very often one of these other compounds can be useful. So again, it's just to make the point that carbamazepine and oxcarbazepine, whereas they're good mood stabilizing agents, in lower dose they do have an antidepressant effect. And then other mood stabilizing agents are sodium valproate or Epilim, topiramate or Topamax, and then the antipsychotic agents. So unipolar mania, the reason why I think it deserves a space on its own is for this reason, that lithium only prevents recurrences in about 40% of instances. If you add carbamazepine or oxcarbazepine or any of the other agents to it, it'll bring that up to maybe 60%, but you're still 40% short of prevention for a lot of people. And in those instances, it's often necessary to use one of the antipsychotic agents with it. Now, in terms of unipolar mania, what often happens is that at a later stage in that person's life, their high mood occurring on its own changes to highs and lows. Okay, so again, it shows you that how the brain responds to chemical changes within it, both in terms of responding to different medications, changes over the decades. For bipolar 2, how do you prevent that? In other words, this is where you've got a high, a mild high, and a low, with periods of wellness of months in between. The aim, again, is basically, right throughout all of this, is to deal with the elation first. You have to get on top of that. If you don't get up on top of that, you're not going to get anywhere. And in these instances, what's been found is the things that work best are the anticonvulsant mood stabilizers. So initially what you've got to do is, if the person is having frequent relapses, is to reduce or discontinue the antidepressants, because they can be driving the elation. And then the second point is using the anti-epileptic mood stabilizers. They are carbazine, oxcarbazine, sodium valproate. And then the third line would be using one of the antipsychotic agents. And it's going through definite trials of that, because we have no way of predicting who's going to respond to what. And I'm putting them in the order of the ones that are sort of least side effects, less interventionist. So in other words, you'd have less side effects with just simply reducing the antidepressants. And then the anticonvulsant mood stabilizers will be less problematic than using things like olanzapine and so forth. And bipolar 3, again, just reminding you, bipolar 3 is basically bipolar 2 that's been triggered by substances. So the first thing is to phase out the antidepressants slowly, or whatever agent is triggering the thing. And to use the mood stabilizers as we did with bipolar 2. And then for rapid cycling problems, you've often got to look at why they happen. And you can divide them into two categories, I think. One is where they, right from the onset, they are rapid cycling, day one. And then there are other people where the rapid cycling is an extension of bipolar 2. In other words, but as the years go by, the interval between the cycles, the episodes, is getting shorter and shorter and shorter. So somebody might have started with unipolar depression, just having high lows, and then after a number of years, they might move to bipolar 2. And then into the middle years, it's often rapid cycling. Now, why that happens, it's not too clear. there are case reports of people who've never had any mood stabilizer or antidepressant. Occasionally you'd meet a patient who might present for the first time in their 60s, for example, with a rapid cycling pattern, and they will describe having episodes of depression and then maybe small highs and then rapid cycling, evolving in that way, but coming on in the middle years. And that's probably related to the way the brain responds differently to the hormonal changes that happen. What do I mean by hormonal changes? How the whole dopamine and noradrenaline and serotonin systems go in the brain, and how they are affected by changes in sex hormones is often quite dramatic. So you will often find, for example, if you use antidepressants in teenagers, it often has a very agitating effect on them. And they're generally a no-no, if at all possible, in people in their teens, because it can make them extremely agitated. Likewise, in later life, you might have somebody who's going through their life and they're fine on a certain dose of an antidepressant, no problems, year in, year out, and then they come to the middle years and they get agitated on that same dose of antidepressant. So it has to be reduced. So it's a reflection of how the brain is able to cope with that antidepressant at that point in time. And it's the same with any substance, sex hormones, steroids, alcohol and so forth. A person's brain tolerance for these substances will vary with the years. So as I said, the second group of people are people who develop it from the sudden jolts in hormones at certain phases, postnatally, midlife hormonal changes for both men and women, removal of ovaries, steroids or thyroid deficiencies. And as I said, after years of wellness on antidepressants, the person can begin cycling. So in terms of prevention of relapse in rapid cycling, it's again phase out the antidepressants, use the anticonvulsant mood stabilizers. Whereas lithium isn't highly effective here, it still will work perfectly well for about 30% of people. But that's the same type of response rate that you'll get from any one of the treatments in rapid cycling mood disorder. But it's not the same 30%. But generally, in most instances, with rapid cycling mood disorder, you will get a solution. But it can often take quite a while because you've got to put the person through a trial of each one for a period of time, not days or weeks, generally months, before you can determine whether it's working. Because rapid cycling is a bouncing ball phenomenon. And it takes a while to say, oh, it's beginning to peter out. So it's not something that you're necessarily going to see happening overnight. So what can you do in terms of preventing relapse? One of the things that's looked on these days is trying to help people to have a sort of a sense of mindfulness, using exercise, using yoga, anything that has a calming effect. Because there's no doubt about it that anxiety or anything that is a threat to a person will activate the brain. And for most of us, when we're activated in that way, it's generally a productive thing. But for somebody who is inclined, as I said, to go into very high gears in response to that and kickstart a high, that's a problem. So these are just some of the techniques that are used, from things such as, I'm not going to go through these in detail, but mindfulness, learning to tolerate distress, being aware of thoughts and emotions, validating your emotions. In other words, when you feel anxious or you have a certain view on something, how true is that? If it's upsetting you, what is that about? Is there evidence for it or not? Resisting urge to fuel urges that fuel elation. For example, watching certain things that are going to have an emotional upset on you, using things like alcohol and so forth, and using a sort of a wise mind approach where we take into account our thoughts and feelings about things in a balanced way. And then learning to what they call radical acceptance. But that's really knowing when to let go of something and not keep wrestling with it. So, dealing with addictive behaviours, alcohol, drugs, gambling, sex, food, because again, there is a connection between the genetics of bipolar disorder and some of the addictions that happen, and they do overlap. And all of those substances are mood altering. Dealing with anxiety, social anxiety and panic, we know that something like 50% of people have comorbid anxiety problems, general anxiety, OCD, panic disorder, social anxiety, and they need to be treated once the bigger picture of the bipolar illness has been contained. And sorting out relationships that have been affected by the illness is important in terms of preventing relapses. So what can you do now? Well, first thing is to acknowledge the illness, don't reject it. It's a real phenomenon. I know there's a tendency to change the name of the condition, give euphemistic names to it and so forth, and that's okay. One understands why that's a problem for people. But we need to be careful that we don't disown it totally, because if you don't face a condition like this and get to understand it and understand the mechanisms behind it and how they relate to you, it's hard to deal with it. So getting to know it and how to overcome it, and despite what we know about CBT and psychotherapies and different types of interventions, mindfulness, all of those may be helpful in preventing episodes. But when it comes to treatment, there's no evidence that any of them work if the person's mood is significantly disturbed, either in a depressed way or a manic way. There is no literature that will give support to that type of view. Not knocking those interventions, they are important, and if they do help to keep people calm and keep them in a relatively anxious-free state, the chances of a relapse is significantly lessened. Acknowledge the effect of the illness on relationships. In other words, encourage your family to get support, to attend things like aware support groups, and for you to do likewise. The key thing in terms of managing relapse is being able to spot the relapse. If you can spot an emerging elation and nip it in the bud, it's not a problem. Patients should be encouraged to do that, and there are 3 ways you can do it. You have the ordinary signs and symptoms, and they're quite good for spotting depressions, spotting many of the symptoms of elation, but not necessarily by any means all of them. When you go, if you're attending a doctor with bipolar disorder and you report between your visits how your mood has been in terms of depression and elation, and what research is showing is that about 26% of the days that a person has been depressed are reported to the doctor at the visit. The rest isn't. And only about 17% of the high days are spotted. So that what a person reports at the session is determined by their mood on that day or 2 or 3 days beforehand. Not for the previous week, not for the previous month, not for the previous 6 months. So in terms of the clinician getting a good handle on what the pattern of the mood is and how much intervention is needed, that will become, I think, a key aspect of preventing relapse is using some sort of daily monitor. Then when people get high or low, they often do things that are characteristic, and this becomes important when somebody is high. Some people, for example, will dress in a particular way or take an interest in certain films or music or whatever, or wear a certain pullover that they wouldn't be seen dead in at any other time. And the family spot that, and it's useful. But sometimes the particular patient spots it too, and they no longer wear pullovers. But the point is, it is a useful indicator. But the ultimate way is appointing a spotter, and this is a term derived by aware support group members, and it's to indicate the necessity to engage a family member, because family members can spot an elation at a mile. They can spot it by the way a person holds their head, the tone of their voice, what they're talking about, whereas the clinician won't spot it that quickly unless they know the person extremely well, but they still won't spot it that quickly because of the formality of a clinical session. Okay. Sometimes you'd see people who come along here for admission in the admission office. You'd sort of wonder, well, why were they referred into hospital? There's nothing much wrong with them. And 10 minutes later, you could see them on the ward, and you'd see they're really quite elated. So what we advise is that the person who is unwell, once their mood settles, that they pick a family member or somebody whose judgment they trust to tell them at a time they think they're high that their mood has shifted and that they need to get help. But it also extends to, you've got to take the car keys away from me, take away my credit cards, whatever you think is necessary, even if that means bringing me to hospital and making sure that I get in there and get treatment. That's an invasion of somebody's privacy and their independence and so on. Yeah, well, that's the choice. Either let bipolar rule your life or somebody you trust. So, and it works extremely well because it's very clear that the amount of time people spend unwell, in hospital, out of work, out of their families and so on, is dramatically reduced by using that process. And this goes hand in hand with item 4, the spotter, is arranging an emergency supply of medication with your doctor that will enable you to adjust your medication to sort of get on top of the thing immediately, rather than even waiting a day or two. Know the triggers: alcohol, coffee, lifestyle issues. Be aware of the daily lifestyle list, in other words, having a structured day and a structured existence. And finally, to talk over the hurts that you've gone through in life. So in summary, yes, you can overcome bipolar disorder, but you've got to know it. A lot of it makes sense, a lot of it is sensible, a lot of unknowns, that's for sure. Still waiting for the really big breakthroughs in treatment. Treatment is not, by and large, the big issue. The big issue is the interval between the onset of the condition, it being diagnosed correctly, and the length of time it takes then to finally get the thing stabilized. So during that time in a person's life, a lot of things can go wrong. Relationships end, work goes astray, people fall out of education, get into difficulty with the law, and that's a lot of pain and suffering for the person and their families. And that's where a lot of our focus is on these days, in terms of how can we help people, I suppose, to help themselves. Because in many ways, the amount of detailed monitoring of mood when people are unwell needs to be at the level that is readily available for people with diabetes. The similarities are very much significant. We still haven't found the glucose in the system for, as it were, bipolar disorder, and I wouldn't be as brash to suggest that it's uric acid, but who knows. Thank you.